Assalamu alaikum. Today I'm going to read academic clinical case number 22, that is an 11-year-old girl with delayed puberty. This case presents an 11-year-old girl with delayed puberty, short stature, and a series of dysmorphic features, including wide spaced nipples, cubitus vulgus, and hyperconvex fingernails. Given these clinical features and her lack of progression in secondary sexual characteristics, the most likely diagnosis is Turner syndrome. Turner syndrome is a chromosomal disorder affecting females, typically caused by the complete or partial absence of one X chromosome. It affects approximately 1 in 2,500 live female births and accounts for a significant proportion of spontaneous miscarriages, with around 15% of such miscarriages showing a 45X karyotype. This condition arises due to genetic abnormalities, most commonly the loss of the paternal X chromosome, around 60% of cases. Other causes include mosaicism, where some cells have a normal karyotype while others are 45X and less frequently ring chromosomes, or deletions of parts of the X chromosomes. Unlike conditions such as Prader-Willi syndrome, the Turner syndrome does not involve genomic imprinting. The absence of the second X chromosome disrupts normal female development. The X chromosome contains genes essential for growth, sexual development, and various physiological processes, and lack of these genes results in the characteristic clinical features of Turner syndrome. The hallmark signs include short stature, which is often evident by early childhood, and ovarian dysgenesis, leading to delayed puberty, primary amenorrhea, and infertility. Girls with Turner syndrome typically have a height below the third percentile by adolescence, even if their parents are tall. The SHOX gene, located on the short arm of the X chromosome, plays a crucial role in bone growth, and its deficiency contributes to the short stature seen in Turner syndrome. Growth hormone therapy, if initiated before the closure of epiphyseal growth plates, can help improve final height in these individuals. Ovarian dysgenesis in Turner syndrome results from the loss of functional ovarian tissue. This leads to insufficient production of estrogen and progesterone, causing failure of secondary sexual characteristic development, such as breast growth and menstruation, while pubic hair development is normal due to adrenal androgens. But breast development remains absent or delayed. Estrogen deficiency not only impacts reproductive health but also has systemic effects, including reduced bone density, which can lead to early onset osteoporosis and scoliosis. These complications highlight the importance of estrogen replacement therapy, which is typically initiated around puberty to mimic natural pubertal development and prevent long term skeletal complications. The condition also associated with various dysmorphic features, including a webbed neck, low posterior hairline, a broad chest with widely spaced nipples, that is called shield chest, cubitus vulgus, high arched palate, and hyperconvex nails. These features, although not life threatening, but can affect self esteem and body image, especially during adolescence. Many individuals also have short fourth metacarpals and a tendency towards ptosis or strabismus. In addition, Turner syndrome frequently involves congenital abnormalities, particularly in the cardiovascular and renal system. Common cardiac defects include coarctation of aorta and bicuspid aortic valve, which can predispose to hypertension, aortic dissection, and other cardiovascular complications later in life. Renal anomalies such as horseshoe kidneys and duplex ureters occur in up to 60% of individuals, although they rarely impair renal function. Turner syndrome does not typically affect intellectual development, and most affected individuals have normal IQs. However, there may be specific difficulties with visuospatial skills, mathematics, and non-verbal problem solving. Psychosocial challenges, including feeling of social isolation and difficulty forming peer relationships, are also common and may require support. In terms of pathology, the condition reflects the absence of one functional X chromosome in all or some cells in case of mosaicism. The individual may have a mixture of 45X cells and 46XX or other karyotypes. This mosaicism can result in a milder phenotype, with some individuals experiencing partial ovarian function or less pronounced growth failure. Karyotyping is the diagnostic gold standard for Turner syndrome, as it can identify the chromosomal abnormality directly, while advanced techniques like array comparative genomic hybridization are highly sensitive for detecting deletions or duplications. They are not suitable for diagnosing conditions involving whole chromosome loss or mosaicism, which makes karyotyping essential. Patients with Turner syndrome are also at increased risk for autoimmune conditions, particularly Hashimoto's thyroiditis, which can lead to hypothyroidism. Regular thyroid function testing is recommended. Hypertension, even in the absence of renal or cardiac abnormalities, is more common and requires ongoing monitoring. Life expectancy in individuals with Turner syndrome may be slightly reduced due to cardiovascular complications such as aortic dissection or ischemic heart disease. But with proper care, most individuals can lead to healthy and productive lives. Fertility is generally impaired, but advances in assisted reproductive technologies, including in vitro fertilization with donor oocytes, offer hope for women with Turner syndrome who wish to have children. The management of Turner syndrome requires a multidisciplinary approach, including endocrinologist, cardiologist, nephrologist, psychologist, and reproductive specialist. Growth hormone therapy is recommended to improve final height, while estrogen replacement therapy is essential to initiate puberty and protect against osteoporosis. Cardiovascular and renal anomalies must be monitored and managed appropriately to prevent complications. Regular screening for associated conditions such as hypothyroidism, hypertension, and scoliosis are critical for ensuring optimal health outcomes. With advances in medical health and a coordinated approach, individuals with Turner syndrome can achieve a good quality of life and long-term health. Here is the first question asked in this case is which of the following is the most likely diagnosis? Select one answer only. Let's rule out one by one. Number 1, constitutional delayed puberty. This is a common cause of delayed puberty but is not associated with dysmorphic features like those seen in this case. Additionally, constitutional delay would not explain her short stature and other physical findings. Next option is growth hormone deficiency. While growth hormone deficiency can result in short stature and delayed growth velocity, but it does not cause the dysmorphic features or pubertal delays seen here. Next is hypothyroidism. Hypothyroidism can cause short stature and delayed puberty, but additional symptoms such as lethargy, constipation, dry skin, and a slow growth velocity typically present. It does not explain the dysmorphic features in this case. Next is Noonan syndrome. Noonan syndrome shares some features with Turner syndrome, including short stature and cubitus valgus. However, Noonan syndrome is characterized by hypertelorism, ptosis, and right-sided cardiac lesions, which are not present in this girl. So, all the features indicated diagnosis of Turner syndrome that I already explained. Here is the second question. Which investigation would be most likely to confirm the underlying diagnosis? Select one answer only. Let's rule out one by one. Array comparative genomic hybridization. While array CGH is highly sensitive for detecting microdeletion and duplications, it cannot detect low-level mosaicism or balanced chromosomal abnormalities. It is not the first-line investigation for Turner syndrome. Second option is fluorescent in situ hybridization. It is sometimes used for detecting specific chromosomal deletions or rearrangements, but it is not necessary in this case because Turner syndrome is best identified using karyotyping. Next option is MR brain. This test might be used to investigate central causes of delayed puberty such as hypogonadotropic hypogonadism or pituitary abnormalities, but there is no indication of such issues in this case. Next is thyroid function test. Although hypothyroidism is more common in Turner syndrome and should be monitored, it is not the primary test for diagnosing Turner syndrome. So the karyotyping is the gold standard diagnostic test for Turner syndrome. Now the last question, which treatment is most likely to prevent a complication? Select one answer only. Let's rule out one by one. Growth hormone. Growth hormone can improve final height in Turner syndrome if started early, but short stature itself is not a complication that poses health risk. Next option is laparoscopic gonadectomy. This is only indicated in Turner syndrome patients with mosaicism that include Y chromosome material due to the risk of gonadoblastoma. There is no evidence that this patient has Y chromosome material. Next is penicillin prophylaxis. This is used for preventing complications in conditions like rheumatic fever but is irrelevant in this case. Next is thyroxine. While hypothyroidism is common in Turner syndrome and requires treatment, there is no evidence in this case that the patient has thyroid dysfunction. So the answer is estrogen therapy. Estrogen therapy is crucial for girls with Turner syndrome who have ovarian dysgenesis. It facilitates the development of secondary sexual characteristics, for example, breast development. It promotes psychological maturation and improves bone density. This prevents complications such as osteoporosis, scoliosis, and pathological fractures. It is typically started around 12 to 15 years of age. Thank you so much for listening. This is all about from this case. If you have any question, comment below, like, subscribe, and share.